And our today's topic, medical management of older patients with fragility fractures. And our special lecturer today, Dr. Sithira Seniviratna, consultant geriatrician, National Hospital of Sri Lanka. Let me give a few moments to introduce our precious lecturer. And I think most of you know him by name and as a consultant, but he was a star performer and very keen person in the society since he was from since his school time. He was from Mata Rahul Vidyalaya and got the best results of A level in 2008 and attended to the Faculty of Medicine Colombo and was a star performer for the faculty and has become a consultant geriatrician, and he was a role model all through his academic career and still carrying on as a star. Now he's a secretary of Sri Lanka Association of Geriatric Medicine and the secretary of Fragility Fracture Network of Sri Lanka, and he's a council member of Asia Pacific Fragility Fracture Network and a committee member of Asian Falls Network. He's an enthusiastic researcher and he's more interested in orthogeriatrics and palliative care in elderly. So I warmly welcome Dr. Sidhira Seneviratne. Sir, over to you.
Thank you very much for that generous introduction. Hope you all can see me and hear me. So let me share my slides. So today's topic is, medical management of fragility fractures. So when we talk about fractures, we always talk about surgical management of fractures. So today I am trying to open up a different perspective of fractures. So that's the medical side of the fractures, something else other than the surgical side. Right. So my objectives would be, firstly, we'll go through some definitions and so introduction to the topic, and then we look at some statistics and then acute care to rehabilitation of fractures, as well as we'll discuss about prevention and care coordination of fragile fractures. So this is why we are talking about geriatric medicine nowadays. I hope you can see the graph. So Sri Lanka has the fastest aging population of South Asia. And as you can see, we are in 2026 now, and we have about more than 18% of our population, well, the last census being more than 60%. And this trend is going to be, increasing. And in 2040, we are expecting 25% of our total population to be more than 60, as well as, it will go up to 45% at some stage. Right. Okay. So what are the challenges facing with this rapidly aging population? So fragility factors is of course one problem faced by older adults, and we'll go through the definition. So by definition, fragility factor is a break in the bone resulting in low energy trauma. Right? Most of us have seen patients with osteoporosis, frailty, and falls. They result in fractures even with minor trauma, minimum trauma. Slip and fall at home result in multiple fractures. This is, in contrast to high velocity trauma, which result in fractures, especially, younger population who encounter probable road traffic accident. That type of fractures are different from this type of fractures. The common fractures are hip fracture is the prototype fragility fracture in old adult and associated with lot of mobility and mortality. And also other types of fractures are vertebral fractures, wrist fractures, and there could be other fractures as well. Right. Okay. So just we'll to concept this, understand the concept of fragility fracture. Let's go through these scenarios and see whether these are try to categorize whether these are fragility fractures or whether they are not fragility fractures. Okay. The first one, 85-year-old patient having right side hip fracture following a fall in the living room. So do you think it's a fragility fracture? You can type in the chat box. Yes, fragility fracture. All right. The second one, 45-year-old male presenting with fractured humerus following a road traffic accident. Is it a fragility fracture? It's not a fragility fracture. So it looks like it's a high trauma fracture, isn't it? 75-year-old female presented with lower back pain and found to have multiple vertebral fractures. Is it a fragility fracture? Yes, fragile fracture. So, yeah, with minimum trauma, older patients can get vertebral fractures. And another older patient presenting following a fallen from a tree, but fallen from height, and presenting with multiple rib fractures. There is fragile fracture. So, this patient might be having osteoporosis, but we can't, categorize this fracture as a fragile fracture because, by definition, it's a low trauma fracture, and if it is a fallen from standing height or less, all right? So, falling from a tree and developing a fracture is not categorized as a fragility fracture. Okay, right, okay, right. So, let's go through some statistics. So now, so this is called the osteoporotic journey faced by the older people. As you can see, as we grow older, the type of fracture, the frequency of fracture type is also changed, right? So during late 50s, early 60s, it's very common to have Polish fractures, all right. But as people grow older and older, they develop first vertebral fracture, second vertebral fracture, third vertebral fracture. They develop multiple vertebral fractures. And ultimately, so these people get hip fractures. So as you can see, these are kind of a journey, right? So it could start with a Colles fracture, but if you don't, do anything about it, if you don't treat what is the underlying osteoporosis, ultimately this will result in a hip fracture at a later stage. Okay, so so now I'm focusing much more on hip fractures because hip fractures are associated with the highest mortality and morbidity in older people, right? So annually, there's about estimated to have 10 million geriatric hip fractures occur annually. That's a huge number, and 75% of these fractures occur in females, right? And the peak age to get a hip fracture is 75 to 79 years. And the outcome of, if you look at the outcome of hip fracture, it's a huge life-changing event for an older person to get a hip fracture. And 40% of older people, even after 1 year, find it difficult to walk after hip fracture. So what do you think is the mortality of a hip fracture? So all around the world, so it has been shown mortality after 1 year is around 20 to 25%, right? Okay. In some studies, it has been shown around 30% as well. So nearly one third of uh, the population who had the infection has chance of dying within 1 year. So it's something associated with a lot of mortality, all right, and also morbidity. So looking at Sri Lankan statistics, so this is one study uh, done by a group of researchers in Sri Lanka. And in this study, they have looked at patients' functional outcome after hip fracture in 1 month, 3 months, and 1 year after the surgery. And as you can see, even after 1 year, according to this study, 75% of patients remain dependent for some type of activities of daily living. Right? So it's not only the mortality, as you can see, it has a lot of morbidity, and it increases. It is associated with high caregiver burden. Right? Just imagine 75% of patients being dependent after 1 year after hip fracture. So you can see the burden of the caregiver burden. All right, we are facing with the fragility practice. Okay, now that's about statistics. I'm moving to discuss few tips about acute care after a fracture. All right. So when it comes to acute care, so again there are some words I want to introduce. So orthogeriatric and perioperative care. All right. So these are somewhat novel terms to our setting. So, orthogeriatric care is geriatrician specialized in management of fragility fracture, helping the orthopedic surgeon to improve the outcome of patients who have fragility fractures. Right. So, perioperative medicine, by definition, is a kind of multidisciplinary subspecialty where the geriatrician helps not only the orthopedic surgeon, other surgeons to improve the outcome of yeah, I think there's a problem with. Let me. Can you hear me? Some people have the chat box included that they can't hear my voice properly.
So
Can
we
you hear
can
me
hear
now?
you. Yes,
All right,
sir, we can hear you.
right, right, right. So, yeah. So I was talking about the orthogeriatrics and perioperative medicine. So when it comes to perioperative medicine, it's actually, yeah, can hear loud and clear. Excellent. All right. So yeah, when it comes to perioperative medicine, so it goes beyond the care of fragility fractures to patients, elderly patients undergoing major surgeries, and geriatricians coming into the picture, helping the surgeons to improve the preoperative fitness as well as postoperative outcomes of these frail older people. Right. Okay. So let's see how geriatrician or physician can help the improving of outcomes of fracture. All right. Right. Okay. And so our main focus is on hip fractures, but now worldwide this care has been extended to femur fractures, spinal fractures, as well as other fractures, depending on the availability of resources. All right. Right. Now, when you think about the predictors of surgical outcome, it's not only the skill of the surgeon, all right, or the type of the surgery that matters. There are several other factors that can, affect the surgical outcome, right? Especially frailty. We call it aging and physiological reserve, all right? Frailty of the older person. If an older person is very much frail, if they have, very much limited reserves, high chance they will develop poor outcomes after the surgery. If they have multiple medical comorbidities, again, clearly, as you can understand, the outcome will be poor after the surgery, right? And if it is extensive surgery compared to minor surgery, outcome will be poor, right? And other problems like other geriatric problems like presence of frailty, malnutrition, cognitive impairment, right? And those type of things also can affect surgical outcome and also social support. So as you can see, it's not only the surgical skill, but also there are a lot of other factors, including medical factors and social factors that will, you know, uh, decide the outcome of these patients. So this acute care, we call it perioperative care. We divide into three phases, right? So preoperative period, intraoperative period, and postoperative period, right? Okay, we'll go through some of the important tips that we have to be aware about when it comes to hip fracture, acute care of hip fracture. So before we do the surgery, we have to diagnose the hip fracture. So currently, if you're someone presenting with hip pain following a fall, and if you're suspecting hip fracture, the first thing is a clinical diagnosis followed by a X-ray to see whether you can see obvious fracture, right? And there's this entity. Sometimes there will be a group of patients who have persistent hip pain, but you can't see a fracture in the X-ray, and we call them probable occult hip fractures. So these type of occult hip fractures sometimes could be discharged, and after mobilizing at home, the pain can get worse, and this occult fracture can become a displaced fracture. All right, these patients, the current gold standard is to offer a MRI to detect the hip fracture, but depending on the resources as well as patients tolerability of a MRI, we also can go for a CT. So you have to be aware about this entity called occult hip fracture as well, right? And now, as I told you, these older patients who have hip fracture, it's not only the fracture, they are multimorbid. They have multiple geriatric problems. So before we put them through the surgery, we have to do something called a comprehensive geriatric assessment, right? And I did some lectures on falls and frailty as well in this forum, and hope I mean people who join the lectures might be might familiar with this term of CGA, comprehensive geriatric assessment. So comprehensive geriatric assessment is a special type of assessment done by geriatricians, going from patients head to toe, look at patients' morbidities, including geriatric syndromes as well as medical morbidities. All right, and so at presentation we have to do a focus CGA. I'll show you an example how to do a CGA in a bit of a time. And a person presenting to hospital with suspected hip fracture and receives care that is guided by timely assessment and management of medical conditions, including cognitive assessment, pain assessment, and nutritional and frailty assessment is also important part of this assessment. And not only the medical assessment, we also have to assess patients' mechanism of injury, as well as we have to see what type of fall the patient has had, It might be important to this perioperative period, and also patient's capacity assessment as well. Right. So these are the things we include into re-op assessment. We do a focus CGA, and also we analyze the acute problem, which are pain and medical complications, and medical history, and patient's functional status, cognitive function, frailty, medication history, alcohol smoking history. It's very important. Sometimes people might develop alcohol withdrawal and nicotine withdrawal symptoms following the surgery. So we need to have idea about those, things. And pulse assessment is quite important. Sometimes these patients, might have had a stroke and fall and a fracture. So the mechanism of fall is quite important. And nutritional status, is very important, especially postoperatively.